Assalamu alaikum warahmatullahi wabarakatuh. Welcome to the channel of Summary of Stand Medical Textbooks. That is nothing but Stand Medical Notes. So let's continue the topic of pulmonary hypertension. Let's start with the name of Almighty. So today we'll discuss about the next topic is clinical presentation and physical examination in patients with pulmonary arterial hypertension. So one line important to remember here is symptoms are often non-specific, leading to average diagnostic delay of approximately 2 years. So because the symptoms are non-specific, there is usually a delay of 2 years in patients with pulmonary hypertension. So to easily remember the symptoms of this pulmonary arterial hypertension, let us understand this with this diagram. Okay, so this is liver and this is the jugular veins and this is the right ventricle. This one is the tricuspid wall. This is the pulmonary wall. This is the pulmonary artery. Okay, and these are the limbs. So whenever there is pulmonary hypertension, so first thing which happens here is there is rise in the right heart pressure. So this right heart pressure, this part pressure will raise whenever there is whenever there is pulmonary hypertension. So first thing which is going to happen is so during systole, pulmonary valves will open. Okay, sorry, during systole, this pulmonary valve and aortic valve will open. So what will happen? So there is a rapid gush of blood which is flowing from the hypertrophied ventricle into the pulmonary artery. So this produces loud P2. Why loud P2? Loud P2 P2 point of the S2, loud P2 of S2. So loud S2 you will hear on the pulmonary side when you auscultate. That is the initial point, and you can palpate this P2, palpable P2 you can say. Loud and palpable P2 you will have, okay, at the pulmonary area on the chest. So with the time, what will happen is because of increased blood volume in the right heart, there is development of a murmur in the pulmonary through the pulmonary wall, and that is nothing but the ejection systolic murmur. So that is the first thing. These are the first thing which are going to happen. So palpable P2 and you hear a ejection systolic murmur. Loud P2, palpable P2 and ejection systolic murmur. These are the first thing which you are going to find in a patient with pulmonary arterial hypertension. Now, as the time progresses, there is hypertrophy of the right ventricle, and as well as there can also be hypertrophy of the right atrium. So when there is hypertrophy of the right ventricle, this annulus of the tricuspid wall, the diameter of the annulus of the tricuspid wall will increase. What this will lead to? This will lead to tricuspid regurgitation. So because this annulus is dilating, why? Because suppose this was this much the wall of left ventricle. Now it will go to here. So with that expansion of right ventricular wall, there is expansion of the annulus of the tricuspid wall. Because of that, there is tricuspid regurgitation jet, and you will have a tricuspid regurgitation murmur. Pan-systolic murmur you will have of tricuspid regurgitation in the tricuspid area. So TR murmur, tricuspid regurgitation murmur, is a sign of right ventricular hypertrophy. Okay. Okay. Now this is the second thing which you will notice: tricuspid regurgitant murmur. Then when there is failure, when there is hypertrophy of the right side of the heart, definitely there will be failure. There will be ischemia of the right ventricle. Okay, there will be ischemia of the right ventricle, and there will be volume overload. So because of that, because of back pressure, there will be increased jugular venous pressure. This is the neck. Okay, increased jugular venous pressure in the upside in the neck veins, and downside, because the inferior vena cava is going here, it is going through the liver, there will be palpable tender hepatomegaly. Palpable tender hepatomegaly. This you will see. Palpable tender hepatomegaly. And with time, you will have ascites and pedal edema in the limbs. So these signs, what are the signs? JVP, increased JVP, and palpable tender hepatomegaly, and ascites in the abdomen, and pedal edema of the limbs signify there is right ventricular failure, right ventricular heart failure. Okay, so this is the third thing which you will notice. So first thing, you will have a palpable T2, a P2, and loud S2 along with ejection systolic murmur. Second thing, you will have a tricuspid regurgitant murmur. Along with, you can have a left parasternal heave. If you palpate the parasternal heave, you will have, because of the right ventricular hypertrophy. So that is the second thing which is going to happen. The third thing is failure part. So whenever there is failure, there is tender hepatomegaly, then rise JVP, and ascites and pedal edema. Okay, so these are not good signs. These are advanced stage of the disease. This signifies advanced stage of the disease. Okay, that's what I want. Now we will learn the symptoms and signs of pulmonary hypertension. By knowing all this mechanism of signs and symptoms, now we will learn about the signs and symptoms properly. So you see here symptoms. So there will be exertional dyspnea, and this is the earliest symptom which is most commonly seen. So exertional dyspnea, fatigue because of low cardiac output. Okay, syncope, inability to augment cardiac output because of fixed stroke volume reaching to the brain. There will be syncope in these patients. And remember one point: syncope is a red flag that signifies imminent right ventricular failure. Chest pain mimics angina but reflects right ventricular strain or ischemia. So exertional chest pain you will have because of right ventricular hypertrophy, RV ischemia due to pressure overload. So these are the symptoms. Exertional dyspnea. What is the cause of dyspnea? Exertional dyspnea because of pulmonary hypertension, pulmonary edema. Okay, fatigue is because of reduced cardiac output. Syncope is when the cardiac output is when the heart is not able to pump. When the heart is, the stroke volume of the heart is fixed because of failure. So that time you will have syncope. That is an imminent sign of right ventricular failure. And exertional chest pain you will have. So this is because of demand supply mismatch because of chamber hypertrophy. So on cardiac examination, what you will have, as I said, so you will have a loud P2, accentuated pulmonary component of S2, and often palpable P2. Okay, and you will have a tricuspid regurgitant murmur. Okay, which is holosystolic, mean pan-systolic murmur. Okay, and you remember one thing: any murmur on the right side of the heart will increase with inspiration because of increased venous return from the limbs to the heart. Okay, increased venous return during inspiration. The murmurs of right side of the heart will increase. That is known as Carvalho's sign. Okay, so there will be tricuspid regurgitant murmur. And one more thing I forgot to say is there is right-sided S3, S4, discussed in detail in the part of heart murmurs and adventitious sounds. Okay, you can go and watch that video. So when there is right ventricular diastolic dysfunction, you will have this triple heart sound. Which are the triple heart sound? One is kintuki. Kintuki is nothing but S1, S2, S3. One is tenesse. Tenesse is nothing but S4, S1, S2. So triple gallop, it is known as gallop murmur. Okay, so triple heart sound you will hear. So when there is right ventricular diastolic dysfunction. So S3 is usually because of volume overload. S3 is because of volume overload, and it occurs in the diastolic. Both of them occur in the diastolic period, but S3 is immediately after S2, and usually it is due to volume overload or volume overload, one thing, and second is failure. It indicates failure. And S4 is because of stiffening of the right ventricle, stiffened ventricle, stiffened ventricle. So the blood is pumped against the stiffened ventricle. That's why you are getting a sound, that is S4 sound, before the contraction of the ventricles. So that is S4 sound. Okay. So S3 can be normal, but S4 is always abnormal. S4 is always abnormal. So remember, just skin to key. Triple heart sound you can hear when there is right ventricular failure or right ventricular hypertrophy. Okay, triple heart sound you can hear in right ventricular failure or right ventricular hypertrophy. Okay, in the context of pulmonary hypertension. So these are the findings. Okay. So the things to note in the signs are loud P2 is hallmark of pulmonary hypertension. Remember this point. I said no, the first sign which is going to be loud P2, palpable P2, loud palpable P2, and usually you will have a ejection systolic murmur on the pulmonary side. And if you see the ECG, you will have P pulmonale there, P pulmonale. Okay, more than 2.5 small squares, P wave in either lead 2 or V1. Okay, tricuspid regurgitation murmur reflects right ventricular dilatation and annular stretch. So I said no, tricuspid regurgitation is a sign of right ventricular hypertrophy in patients with pulmonary hypertension. Venous examination, when you examine JVP, there is prominent A wave when patient has right ventricular diastolic dysfunction. Diastolic dysfunction is nothing but the ventricle is not able to fill properly because they are become stiff now. Okay, that is diastolic dysfunction. Okay, so you will have prominent A waves in GVP. Elevated GVP with V waves is nothing but advanced right ventricular failure, and it is due to right tricuspid regurgitation. So JVP waveform analysis is important. A wave is nothing but right ventricular stiffness, and V wave in JVP is nothing but tricuspid regurgitation. V wave is tricuspid regurgitation. A wave is right ventricular stiffness. So this is the Venous. So these are important things which you should remember. So just now let us see the last point, systemic examination, what you will have. So these are advanced signs of heart failure. Hepatomegaly, you will have congestive hepatopathy. Ascites will have, okay, peripheral pitting edema you will have. These are signs of decompensated right heart failure. Hepatic pulsatility may be present with severe tricuspid regurgitation. Okay, so these are the signs of decompensated or advanced right ventricular advanced pulmonary hypertension. Okay, so these are the symptoms and signs of pulmonary hypertension with concept. Okay, so here you can see a table from Oxford. So just you see, these are the symptoms: exertional dyspnea, fatigue, syncope, exertion, chest pain. You will have a loud palpable P2, often with ESM, S3, S4 and advanced stage, tricuspid regurgitation murmur when there is right ventricular hypertrophy. Okay, syncope is a red flag here. Okay, TR member reflects right ventricular dilatation. Loud P2 is hallmark of pulmonary hypertension. Prominent A wave in GP and V waves signify tricuspid regurgitation. A wave signify RV stiffness. This is systemic examination which you see. And in ECG, what you will see? So earliest sign in ECG of pulmonary hypertension is P pulmonale. So in lead 2, you will have P wave, tall P waves more than 2.5 small squares in lead 2. Or if you see lead V1, so it is usually biphasic. So this first part represents the right atrium and second part represents the left atrium. So this will be elongated. This will become either monophasic or slightly like this. The first valve will be elevated more than one small square. One small square. So this is the earliest sign of pulmonary hypertension, P pulmonale. Okay, and this also signifies pulmonary right atrial hypertrophy. Right atrial hypertrophy. So that's the point. So this is increasing pulmonary vascular resistance, and this is the symptoms of the patient. So in the preclinical stage, meaning when the patient is not having symptoms, the cardiac output will decrease at peak exercise. The patient will not have symptoms until he does an exercise at its peak. So a stage will come where patient will be symptomatic at rest. Okay, symptomatic at rest or symptomatic at less than the ordinary activity, or you can say as stage 3 of NYHA. Stage 3 of NYHA. Less than, see, this is, sorry, it is stage 4, and this is stage 3 and 4, and this is stage 1. Stage 1, so develops only on severe exertional activity. Stage 2 is in ordinary activity, 3 is less than ordinary activity, 4 is at rest. So as the patient moves from this stage to this stage, there is increasing pulmonary vascular resistance and the symptoms of the patients are deteriorating. So that thing this table shows, because the cardiac output is getting decreased and pulmonary vascular resistance is getting increased. Okay. Now, how do you diagnose? What is the diagnostic evaluation in patients with pulmonary hypertension? What is the approach you will follow? So the goal, the aim is to screen, first rule out whether the pulmonary hypertension is present or not. Then once you have screened, then classify it, whether it is WHO stage 1, 2, 3, 4, 5, and then confirm it with right heart catheterization. You will rule out, you will screen with echo, 2D echo cardiogram, classify based upon some investigations which I will discuss, and then confirm by right heart catheterization. 2D echo, then classify based on some specialized test, then confirm by right heart catheterization. So this is the step-by-step algorithm. Okay. So screening is done by echocardiogram. It measures tricuspid regurgitant velocity. If the tricuspid regurgitant velocity, nothing but TRV, is more than 2.8 meter per second, then that suggests pulmonary hypertension. Tricuspid regurgitant velocity, if it is more than 2.8 meter per second, then it is that suggests pulmonary hypertension. Now you will classify. How you will classify? You will rule out the group 2 and 3. Group 2 is nothing but the causes of heart. Group 3 is nothing but the causes of lung. So we'll rule out cardiopulmonary causes first. First we'll rule out cardiopulmonary causes. How you will rule out? You will rule out by doing pulmonary function tests, chest X-ray, CT scan, okay, and left heart assessment by 2D echo. Okay. So left heart assessment, you can find any motion valve abnormality or any valvular abnormality you can have. So by that you will see the heart also by 2D echo itself. For lung, you will need to do PFTs, chest X-ray, and HRCT. So you will rule out group 2 and 3. Having ruled out group 2 and 3, then you will rule out the group 4. Group 4 you will rule out. What is group 4? Chronic thromboembolic pulmonary hypertension. So for this, ventilation perfusion scan is mandatory. A normal V/Q scan essentially rules out chronic thromboembolic pulmonary hypertension, CTEPH. CT pulmonary angiography can also be used, but it is less sensitive for chronic clots. So either you can have V/Q scan or CT pulmonary angiography, but V/Q scan is mandatory to rule out this CTEPH. So, but you have ruled out 2 and 3, 4. So now either it can be 1 or group 5. Okay. If you have found it as 2 or 3 or 4, you will act accordingly. But 2 is not there, 3 is not there, 4 is not there. So mostly it is type 1. Mostly it is type 1 because type 5 is very much rare. Now you will confirm with right heart catheterization, which is the gold standard. So in group 1, one thing you should rule out when you have confirmed by right heart catheterization, that is vasoreactivity testing. What is this vasoreactivity testing? So you by this vasoreactive testing, you want to know whether these patients respond to calcium channel blockers, which are vasodilators. The calcium channel blockers, high dose calcium channel blockers, which are used for hypertension, like nifedipine, amlodipine, whether they are respond to this, because approximately 10% of patients of group 1 have vasoreactivity. So if they have vasoreactivity, if the vasoreactivity testing gets positive, then you can use high dose calcium channel blockers before going to the standard drug treatment for group 1 patients. Okay. So what you will do in that vasoreactivity testing, you use inhaled nitric oxide. So responders, those who respond, will show a drop in mean pulmonary arterial pressure of more than 10 mmHg to an absolute level of less than 40 mmHg. So they will have a drop in mean PAP more than 10 mmHg and absolute level less than 40 mmHg. So they are known as responders. If they respond, then you can use high dose calcium channel blockers in these patients. So that's about vasoreactivity testing. So these are step-by-step investigations which you do in these patients. Now this is a flow chart of how to explaining the hierarchy of diagnosis of pulmonary hypertension. So how do you suspect? Based upon clinical features, symptoms, ECG and 2D echo. On these things, clinical features, symptoms, 2D echo and ECG, you will suspect this. Then you will rule out left heart, meaning group 2 and group 3 disease, meaning heart disease and lung disease. How you will rule out? Ask for risk factors like diabetes mellitus, hypertension, CKD, obesity, smoking, okay, alcoholism, metabolic syndrome. So these are all risk factors. Okay, assess risk factors, then do pulmonary function test along with diffusion, DLCO, nothing but diffusion capacity of the lungs, chest X-ray, HRCT, and arterial blood gases. By these things, by risk factors and these investigations, you will assess the left heart function and lung disease. So once you have made a diagnosis, so that is one thing. One more thing is group 4 you will exclude. What is that group 4? CTEPH, chronic thromboembolism, by doing a V/Q scan. Okay. Now you will confirm it by right heart catheterization. Now, one thing Harrisson says here is RHC indicated for definitive pulmonary hypertension diagnosis and to assess severity? So you should ask this question. So by symptoms, clinical features, and by having these, just but by doing up to here only, if you are so much confident that this patient is having obviously pulmonary hypertension, then you should ask yourself the question whether I need to do RSC in this patient or not to assess for confirmation and to assess the disease severity. If you're not confident, then you should go for right heart catheterization. There you will have 3 parameters to assess: MPAP, as I explained in the previous video, and PWCP, pulmonary capillary wedge pressure, and then pulmonary vascular resistance. So based on this, you will differentiate the causes. So these 2 are mandatory to have pulmonary hypertension in right heart when you are assessing pulmonary hypertension by this. So MPAP more than 20 and PVR more than 3 in this is a, I think, old Harrisson it is given 3, now it is 2 Wood units. So if it is no, then alternative cause of non-pulmonary hypertension cause you should be that should be ruled out. If it is yes, then you will proceed accordingly. So you have measured these things. So you will measure PAWP. If it is more than 15, then probably it is left heart disease. If it is less than 15, okay, and there are no other cause for pulmonary hypertension, meaning no 2, 3, 4 causes, then probably it is pulmonary arterial hypertension group 1. Less than 15 and you have the other investigations like chest X-ray, HRCT indicate obstructive or parenchymal disease, then we'll classify it as group 3. Okay, V/Q mismatch is there, or CT pulmonary angiography shows clots, then you classify it as group 4. Comorbid diseases that are if they are present, which are risk factors for pulmonary hypertension, then you will think of rare PAH. So that's how you proceed. But Harrisson says no need to this all this stuff. If you are confident at this point only, then it is okay, you go and treat the patient. Okay, if you are not confident, one thing to include here is V/Q scan, which is not given here. Okay, so if you do this much only, you will be confident. But if you're not confident, you can go for complete RSC and then you will proceed further like this. Okay, that's about how to investigate. So this is a 2D echo of patient with pulmonary hypertension and changes in this patient. So you can see here there is compression of the left ventricle, D-shaped left ventricle you are able to see in the 2D echo, and there is enlargement of the shadow of the right ventricle. See here, this much. So enlarged right ventricle you are seeing, and compressed left ventricle due to this enlarged right ventricle. So that means there is right ventricular hypertrophy. Okay, this thing you will see. Here you can see there is enlarged right ventricle Okay, along with that you are seeing enlarged right atrium also. Along with that, this arrow points here, this is nothing but pericardial effusion. This is pericardial effusion. Okay, so you can have pericardial effusion and that is a not good sign. Okay, here it is given left heart compression, right atrial dilatation, pericardial effusion are markers of poor prognosis. Left heart compression, nothing but if you see a D-shaped left ventricle in the 2D echo, or right atrial dilatation or pericardial effusion, three things if they are present in 2D echo, then the prognosis is not good. Okay. Okay, so mainly you will see a enlarged right ventricle in 2D echo. That is the basic thing which you are going to see. Okay, and along with that, if you are seeing pericardial effusion, right atrial hypertrophy, and compressed left ventricle, T-shaped ventricle, then that shows it is advanced stage pulmonary hypertension. Okay, then how do you manage? How do you manage the patient? So management can be divided into two steps. So one is general measures. General measures. The second one is targeted therapy. Targeted therapy. So you can see here. Okay. Coming to the first one, general measures, irrespective of any class of pulmonary arterial hypertension, what you will do? Patients should be counseled to avoid pregnancy. One thing, they should be counseled to avoid pregnancy because maternal mortality is very much high. Approximately up to 50% of women who get pregnant with pulmonary arterial hypertension will die because of pregnancy. So it is a strong contraindication for these women. So these women should be counseled to not to get pregnant. And the next thing is sodium restriction and diuretics. So this is the baseline which you are going to all patients irrespective of any class. Sodium restriction and diuretics. So loop diuretics you can use furosemide 20 to 40 mg per hour daily. You can titrate according to the symptoms of the patient. So this will control the RV congestion. Okay. When you are using diuretics, you need to monitor a renal function test and electrolytes, sodium and potassium. One thing is anticoagulation. This is not in all groups. Only in group 4 it is indicated. Chronic thromboembolism, pulmonary hypertension. So there lifelong anticoagulation is required. So you can use either warfarin or direct orally acting anticoagulants directly. Then factor inhibitors like apixaban, rivaroxaban, all these you can use in this group 4. Baseline is sodium restriction and diuretics. Okay, and in some patients, so that comes in group 1. Okay, so these are the baseline. You should say the patient to avoid pregnancy, and you should counsel the patient to restrict sodium, and anticoagulation in selected patients, like particularly in group 4 and some patients of group 1. Okay, these are the general treatment therapy. Now coming to the targeted therapy. So if the patient has belongs to group 2, meaning left heart disease, if the patient has, then the goal should be to treat the underlying heart failure. How you will treat? You optimize the guideline directed medical therapy. Nothing but 4 drugs, either one AC inhibitor, ARB, ARNI, or beta blockers, or mineralocorticoreceptor antagonist, or SGLT2 inhibitors. So you should optimize this therapy according to the patient's symptoms and sign. Vasodilators are contraindicated because they increase the risk of pulmonary edema, as I have explained in the previous video, first part 1 of this pulmonary arterial hypertension. Group 3 is due to lung disease or nothing but hypoxia. So you should treat the underlying lung disease. For example, if it is COPD, give anticholinergic inhaled like tiotropium, and you can give glycopyrrolate, or you can give beta 2 agonists like formoterol, salmeterol. Okay. And if it is interstitial lung disease patient, you can give 2 drugs which are approved. One is pirfenidone. More commonly used one is this one, nintedanib. I will, so 150 mg BD it is given, 150 mg twice daily. So it is antifibrotic agent, antifibrotic in patients with interstitial lung disease. And pirfenidone is given, but I don't remember the dose, but it has more side effects than this nintedanib. Okay, this is I think a Janus kinase inhibitor, JAK Janus kinase inhibitor drug. Okay, so you should use these therapies. And for obstructive sleep apnea, you can give CPAP for the patient. CPAP, continuous pulmonary positive airway ventilation. Okay, so continuous positive airway pressure ventilation is a treatment of choice for patient with obstructive sleep. Remember one thing, drug of choice for patient with lung disease nothing but long-term oxygen therapy. This will improve the survival and it will retard the progression of pulmonary arterial hypertension, because hypoxia is the only cause for hypertension in this patient, pulmonary hypertension. And similarly to group 2 patients like vasculators, you can't use here. You can't use vasculator even in these patients also, because it will worsen the VBIQ mismatch. One important example, COPD patients, what you will do, COPD patients, when you should start this long-term LTOT, this is known as any patient, any lung disease patient, chronic lung disease patient, when you will start this long-term oxygen therapy. This is in detail explained in the class of in the cardinal manifestation of respiratory disease. You can go and watch that last video which I have covered this thing. Okay. LTOT, just I will any patient who is having saturation of less than 88% at rest or on activity. So who has saturation less than 88%, you should start this LTOT. Okay. And any patient who has saturation in between 88 to 90%, so you should start LTO2 in that patient, in those patients if they experience hypoxemia during sleep, one thing, during sleep, or if they have associated cor pulmonale, nothing but right heart failure, they have associated. Okay. Or if they have I think tricuspid recurrent murmur. So all these are criteria when to start. So just remember, if the patient walks and the saturation drops below 88%, or at rest only he is having less than 88% saturation, you should start LTOT, long-term oxygen therapy. And initially it is given 15 hours per day at night, and when the patient experiences symptoms at rest also, you should give it 24 hours per day. So that is all about briefly about LTOT in chronic lung disease patients. Okay. Now I already discussed this one. Group 4 patient with chronic thromboembolic, if they are operable, meaning you can do operation in those patients surgically, you should remove the clot. That is the gold standard, only curative option. If the patients are inoperable, so either of these two therapies you can use. So one thing is pulmonary angioplasty. Second thing is this drug, Rais. So the mechanism of action, which I have explained in the previous video. So 1 mg per oral 3 times a day you can start, and titrate it to 2.5 mg 3 times a day. So Rais improves exercise capacity. So you can use Rais in patients with chronic thromboembolic pulmonary hypertension. You remember this point. Okay. Chronic thromboembolic pulmonary hypertension, as well as in group 1 patient, pulmonary hypertension with no cause, idiopathic. Okay. Rais you can use in these two patients, in chronic thromboembolic pulmonary hypertension and group 1 pulmonary arterial hypertension patients. So remember, before going to the drugs which are used in group 1 hypertension, you should stratify, you should categorize group 1 patient into high risk, middle risk, intermediate risk, and low risk. So low risk and intermediate risk will receive one treatment, and high risk will receive another treatment. So in group 1 patients, the baseline therapy is this one, diuretics with less sodium intake, oxygen, and anticoagulation. This is the basic thing in group 1 patient. Oxygen, diuretics with less sodium, and anticoagulation. This is the baseline therapy. Now, if vasoreactivity test, which is mainly done in group 1 patient, if it comes positive, you can use oral calcium channel blockers like slow release nifedipine or amlodipine or cilnidipine you can use. Okay. But if it comes negative, then you should move to these therapies which I have explained. Okay. So lower intermediate risk, you will start with initial oral combo of phosphodiesterase 5 inhibitor and endothelin receptor antagonist. So dual therapy. If the patient is high risk, then initial combo treatment should include this one, phosphodiesterase inhibitor, endothelin receptor antagonist, along with IV prostacyclin, or you can also give by inhalation route tripoprostenil. This is one more type of prostacyclin which can be given by inhalation route. Then assess the response for 3 to 6 months. So if low risk, then you should follow up the patient. If intermediate to high risk, maximal triple combination therapy, and a time will come when this drug therapy will also fail. Then you can plan those patients for lung transplantation. So you should monitor these patients every 3 to 6 months. If they are better, then say them to come again after 3 months. If they are worsening, you adjust the dose. On maximal dose, still not control, plan for lung transplantation. So this is how you give therapy in patients with group 1 pulmonary arterial hypertension. So vasoreactive responders. So baseline is diuretics with restriction of sodium, oxygen, and anticoagulation. Then vasoactive reactive responders, you give high dose CCBs, amlodipine 20 to 30 mg per day. Diltiazem you can give, nifedipine you can give. Okay, but you remember only 10% will respond, and this requires vasoreactivity testing via the right heart catheterization. Non-responders, initial combination therapy. I said if they are low or intermediate risk, PDE5 inhibitor and endothelin receptor antagonist. PDE5 inhibitor, sildenafil 20 mg TID, tadalafil 40 mg daily, once daily you can give. This will improve the 6-minute walking distance symptoms. Endothelin receptor antagonist. So there are 3: ambrisentan, bosentan, and macitentan. You remember ambrisentan and bosentan, they are used very commonly. Ambrisentan is once daily you can give 10 mg once daily. Bosentan, start with 62.5 mg twice daily per oral for 1 month, then you titrate the dose to 125 mg twice daily. But remember, for bosentan twice daily, ambrisentan 10 mg, bosentan 62.5 mg, titrate to 125 mg BD. Monitor LFT. If LFT is raised, then you should reduce the dose. If LFT is not raised, you can titrate up the dose. Now, apart from this, you can use this Rais 1 mg per oral TID, titrate to 2.5 mg TID. But remember, when you use Rais, you should not use these PDE5 inhibitors because they have similar action. Like AC inhibitors and ARBs, you should not use simultaneously. Okay. Similarly, PDE5 inhibitors and Rais you should not use simultaneously. Either you can use this one or you can use this one. But most commonly, these two are used. Do not combine with PDE5 inhibitors. Prostacyclins. So IV epoprostenol, just remember the names. Oral drug is also there in prostacyclin, that is Selexipag. So IV is epoprostenol. Inhaled is iloprost. Iloprost is inhaled. Remember, iloprost is inhaled. So IV epoprostenol is the gold standard for high risk patients. Abrupt cessation causes rebound crisis. Remember. So once you start these prostacyclins, you should not abruptly discontinue these drugs. Okay. So IV is epoprostenol, which is the gold standard, and inhalation is iloprost. One more time. IV is epoprostenol, inhaled is iloprost, oral is Selexipag. Start with 200 microgram twice daily, titrate weekly to maximum tolerated dose of 1600 mg BD. Okay, you should not discontinue abruptly. So we are proceeding now to the end of this topic. So how you will stratify the risk in these patients who are having group 1 pulmonary arterial hypertension? So you will use some markers to mark them as low risk. Or one more thing I want to say, just you use the NYHA classification, and if 1 and 2 are there, they are low to moderate risk. Okay, consider them the low to moderate risk. Up to 3 you can consider moderate risk, and for patients with 4 you can consider them as severe risk. Meaning even if at rest they are having a breathlessness, then they are high risk. So or you can consider them as 1 NYHA 1 and 2, this as low and moderate risk. 3 and 4, this as severe risk. Okay, so this is an easy method to stratify, but there are some other markers which we can use to stratify these risk, because according to that we will plan the therapy, dual therapy or triple therapy. Okay, so risk stratification prognosis. Treatment is titrated to reach a low risk status. This is also important. So first you will start the treatment according to the risk. Again, what will be the goal? So the goal of our treatment is to reach the low risk status, say 1 and 2 class of NYHA, according to NYHA. Okay, so low risk. So the treatment is titrated to reach a low risk status, which is defined as less than 5% 1 year mortality. Less than 5% 1 year mortality. This is known as the low risk status. Less than 5% 1 year mortality. How will you predict that less than 1%? Less than 5% 1 year mortality by these markers. Less than 5% mortality by these markers. One marker is 6-minute walking distance. So if the patients are able to walk more than 440 meter, so approximately you can take it as half kilometer, or 450 you take or round off. If the patients are able to walk in 6 minutes, they can cover more than or equal to 450 meters, then that is a low risk marker. I said no, WHO class 1 and 2, so that is also a low risk mark. And brain natriuretic peptide or NT-proBNP, so less than 125, so that is also a low risk mark. So that depends upon the age, which I have explained in the topic of heart failure in detail. Right ventricular function is normal and echo, that is also a low risk. Cardiac index more than 2.5 liter per minute on right heart catheterization, that is also a low risk marker. Okay, so very easy among these is which we can see is, so physically physically you can see a 6-minute walk distance, this one, and this NYHA class 1 and 2. Okay, then brain natriuretic peptide, then 2D echo. So these 4 things: 6-minute walk distance, NYHA class, brain natriuretic peptide and 2D echo will predict the low risk status. So prognosis, median survival without treatment was approximately 2.8 years, but has significantly improved with modern triple therapy and transplantation. So survival rate was very much low in this patient before the introduction of this new agents, but now it is significantly reduced. So you should remember the red flags of this pulmonary hypertension or right heart failure, you can say. Okay. So right heart failure due to a pulmonary cause is nothing but cor pulmonale. Or you can say right heart failure due to pulmonary hypertension is nothing but cor pulmonale. Right heart failure due to pulmonary hypertension is known as cor pulmonale. Okay. So these are the red flags you should remember in the emergency department. Right ventricular failure. So when there is patients comes with right ventricular failure, avoid over diuresis because the right ventricle is preload dependent. So volume loss will be there. That's why you carefully give the diuretics. Arrhythmias. Atrial flutter and atrial fibrillation are poorly tolerated. Aggressive rhythm control is required in these patients. Intubation. When do you plan intubation in these patients? Extremely high risk of hemodynamic collapse if you plan intubation in these patients. So intubation is not good for these patients because intubation itself will lower the BP, and your already the patient will be on diuretics for control of breathlessness, and if you intubate the patient again the BP will fall. So there is a high chance of hemodynamic collapse if you intubate these patients. So use inhaled nitric oxide or prostacyclins to bridge to a specialist center. Instead of intubation, what you will do, you will use inhaled nitric oxide and prostacyclins before going to a specialist center. Okay. So inhaled prostacyclin is like iloprost. Okay. Arrhythmias, what you should use? Rhythm control, meaning you can use, for example, atrial flutter and atrial fibrillation are there. Rhythm control you can do by commonly used drug flecainide. Okay, flecainide you can use. Flecainide, okay, group 2A of Vaughan-Williams classification, I think, or ibutylide. So these are the drugs which are used for rhythm control, or very commonly used amiodarone. Amiodarone itself can be used for rhythm control of this atrial flutter and fibrillation because they poorly tolerate this one. Okay, so these things you should remember. Right ventricular failure, you should not over diurese the patient, otherwise there will be hemodynamic collapse. You should not intubate because of risk of collapse. And fibrillation or flutter, meaning arrhythmia, treat immediately, treat aggressively, control the rhythm because they poorly tolerate these arrhythmias. So this is the end of this topic. Thank you, and we'll come with some new topic from the next one.